So good morning all. In today's session, we have our own Dr. Dhiren Ganjwala sir. We all know that he is President of Pediatric Orthopedic Society India, and he will take us through the management of crouch in cerebral palsy. Dr. Dhiren bhai, kindly share your screen.
Sure. Right. Good morning, friends. So basically, we are going to discuss a very important topic about cerebral palsy management. And a lot of children, particularly when they are in adolescent age group, they suffer from crouch gait. So crouch gait is basically the knee flexion gait with the ankle is in dorsiflexion during the stance phase. That is what we understand about the crouch. Now, there are few important questions about management of crouch. The first question is why we really need to treat crouch gait. The second question is what are the factors which are responsible for crouch gait. And the third is how to manage crouch. So in my talk, I will try to cover the first 2 points. What are the reasons why we need to manage crouch? And second, what are the causes of crouch? In the case discussion, we will take care of the third point, and whatever we have discussed in the lecture, we will try to use that knowledge in the case discussion. So the 2 points which will be focusing the ill effects of crouch and the causes of crouch. So let's start with the first area or the first point, ill effects of crouch. There are 4 major problems which we see because of the crouch gait. And I will discuss each of them one by one. I will try to make it as simple as possible, but if you have any question, please raise your hand, and in between also we can discuss. So it's not necessary that we continue with the doubt in your mind. Please feel free to ask questions in between. So the first problem is like the crouch gait increases the demand of quadricep muscles. To understand that point, let's see this figure, particularly during the mid stance, the middle part of the stance, when the knee is extended, the knee and the body remains upright without any muscle force. The reason is the ground reaction force is in front of the center of the knee joint. And because of that, that is producing an extensor component. And then there is a capsule at the back of the knee. So on one side, there is a ground reaction force. On the other side, there is a capsule. And that helps us to remain the knee extended without any muscle force. This situation changes with the flexion deformity at the knee joint. So now we have a patient who has a 20° of the flexion deformity at the knee joint. Now, if we see the ground reaction force has moved posterior to the center of the knee joint. And because of that, now instead of extensor component or moment, it is now producing flexion moment. And now in this situation, the person has to or wants to remain upright, then person requires a quadricep action. So when knee can be extended, we don't need quadriceps, but when knee remains in flexion, we need quadriceps. With more knee flexion, like now there is a 40° flexion deformity, the ground reaction force has moved further posteriorly away from the center of the knee joint, and that reduces the distance of the ground reaction force and the center of the knee joint, and that leads to increase in the lever arm. And now ground reaction force produces more flexion moment, and we need a stronger quadricep action so that the body can remain upright. So I compare this situation is like a coolie at the railway station. Usually they carry one bag, but because of the knee flexion, because of the crouch gait, the quadricep is acting very hard And this is like a coolie carrying 3 bags over the head. So this is the first thing, like crouch gait increases the quadriceps demand. Coming to the second point, it prolongs the quadriceps action. Let us see how it affects. We know that in gait cycle, we have stance phase and the swing phase, and quadriceps is mainly effective in the period of initial contact where it works eccentrically, and later on it works concentrically. So quadricep is working mainly during the initial 1/3 of the stance phase. So almost that comes to 15% of the gait cycle quadricep is active. However, when there is a knee flexion, we saw that to keep the body upright, the quadriceps has to work all throughout the stance phase. So this is can be seen very well. Look at this person's quadricep muscle. Because of the increased demand, the bulk of the quadricep is really great, and the quadricep muscles are working all throughout the stance phase. So both it requires more efforts and it requires a prolonged efforts. And I consider this with a orthopedic resident, instead of like working for 8 to 10 hours, they are so busy and they have to work for 16 to 18 hours and they don't get time for lunch or dinner. So this is what the comparison with the orthopedic residents when they are working very hard for prolonged hours. The third problem is it increases the loading on the patellofemoral joint. We know that the loading on the patellofemoral joint can be calculated by a 2 forces parallelogram. The one is the force by the patellar tendon and the second is by the quadriceps. And when we draw a parallelogram like this, the resultant action tells us about how much force the patella is exerting on the trochlea. Now let's see the similar figure with the knee flexion. In this case, because of the knee flexion, now the 2 forces, their direction is changed, and that leads to a new parallelogram like this. So if you compare the left and the right, we can see that with the knee flexion, the amount of force the patella or the quadricep mechanism is exerting on the patellofemoral joint increases significantly, and that leads to early patellofemoral arthritis. No doubt we don't see that in the adolescent phase, but over the years, if we don't treat, this results into a problem of patellofemoral joint. The fourth problem which we see very frequently, very early, are the stress fractures at either the inferior pole of patella. As shown over here, this is a 10-year-old child. We can see that there is a avulsion or the stress fractures at the inferior pole of the patella on the right side. This is another patient where we can see a big chunk of inferior pole of patella as separated from the patella. And this is actually a stress fracture. It's not really a traumatic injury. But if we palpate, there is a tenderness at that particular point. The same thing can be appreciated at the tibial tuberosity at the insertion of the patellar tendon. So in nutshell, there are 4 ill effects of Crouchgate: the increased quadricep demand, the continuous action of the quadriceps, increased loading at the patellofemoral joint, and because of the increased loading, there is a stress at the inferior pole of patella or the tibial tuberosity. So this explains the reason why we need to treat Crouchgate. Now, once we understood that these are the reasons, we come to the second point. And this is very important for the management, because to manage any problem, first of all, we need to identify what are the causes which leads to Crouchgate. Okay, so I think that before we move on, if we have any question, I would like to stop at this stage and would like to take questions related to the ill effects of crouch. Okay, if there are no questions, then let's move further to the most important point. And this is very important for us to understand how to treat this patient. So the first question which we need to ask is, how do we remain upright? And why this question is very important, because crouch is considered to be a failure of the mechanisms which helps us to remain upright. In our body, there are three groups of muscles. They are working together to keep us upright. The first, if we starts from proximally at the hip, it's a hip extensors or the gluteus maximus. Here, hamstrings also play a very important role in maintaining the hip extension. Then at the knee, we have quadriceps, and at the ankle, we have soleus. So these muscles are called anti-gravity muscles. And when these anti-gravity muscles, they are ineffective, this results into crouch. So in simple, it's very clear that these three groups of muscles, when they are not working effectively, the crouch gait will result. So now we try to understand that what are the factors which are responsible for ineffectiveness of these muscles. So we will see one by one what are the problems at the ankle, what are the problems at the knee. The problems at the hips are not really well understood at this stage, so we will not discuss that. But the problems at the ankle and knee are very clear, and that we will discuss in this remaining lecture. So the question is like, why do these muscles, they become ineffective? When we talk of the muscle effectiveness, we need to remember that there are two important components. The first is the strength of the muscle, and the second is the lever arm problem. The strength is a very old concept, so we all know. The lever arm is a newer concept. To give example of that, we need these 2 points. If this batsman wants to hit a boundary, then he needs a good muscles of the forearm muscles, of the wrist muscles, so that he can swing the bat. So we all are clear that they need a good muscles. However, to understand the importance of lever arm, let me give you a situation that instead of this proper length of the bat, if I ask this batsman to play or to bat with a bat which is very small, his muscles are still the same powerful muscles, but will he be able to hit the boundary? The answer is very clear that he cannot. And the reason is itself is telling that because the length of his bat is small, he is not getting adequate lever arm, and due to that, there are problems with the force being generated, and because of that, he cannot hit the boundary. So the point which I want to hammer is both muscle strength and the lever are important. We look at the muscle strength very well, we measure the power, but we rarely look at the lever arm problem, and this is a very important problem. So now let's come to the question that how soleus become inefficient, how soleus is affected. There are various reasons for the strength reduction which is taking place at the soleus. The first is a neurological problem. All children with cerebral palsy, they have upper motor neuron lesions, and all upper motor neuron lesions have one of the cardinal feature is weakness. So because of their primary brain lesion, the weakness is inherent part of the cerebral palsy children. The second is we are very enthusiastic in giving ankle foot orthosis. And when we give ankle foot orthosis for a long period, it inhibits the movement at the ankle joint, and that leads to disuse atrophy of the soleus. The third is the recent literature has proved that a frequent use of botulinum injection produces fibrosis in the muscle, and it leads to weakness of the muscle. And the fourth, which is very like recently we have realized, and time and again we emphasize in the conference, that many times we create soleus weakness iatrogenically by surgery. So to emphasize that point, I would show some of the figures so that this concept become clear. When we are talking of a diplegic cerebral palsy child, and we are talking of the problem of the ankle joint, we need to understand that the diplegic children, the major involvement is with the biarticular muscles. When we talk of a calf muscles, we are talking of two muscles, the gastroc and the soleus. The gastrocnemius, the one which is shown in a red, is a biarticular muscle and is mostly affected in diplegic cerebral palsy children, and it's a short muscles. On the other end, the soleus, which is monoarticular muscles, is not affected mainly or to a large extent in cerebral palsy diplegic children. Now, if we carry out a tendo Achilles lengthening, a very easy surgery, what happens? The tendo Achilles lengthening carries out a Z lengthening at the tendon level. And that results into a correction at the ankle joint. But what happens proximally at the muscle level? The gastroc, which was short, become normal in length. So from red, I have shown it to green. But what is a problem at the soleus? The soleus to begin with was a normal length, and tendo Achilles lengthening make it further long. So there is an unnecessary lengthening of soleus because of we are carrying out a procedure at a tendon level. That's a tendo Achilles lengthening. So this leads to, let's think that 1 centimeter unnecessary lengthening of soleus has taken place because of the soleus. The Scott Dell has shown very well by a biomechanical model that 1 centimeter unnecessary lengthening of soleus in the form of tendo Achilles lengthening reduces the strength of soleus by 50%. I don't want to say that soleus gets stretched only by surgery. We have seen many children who are not operated. Even in them, the soleus gets stretched without surgery. So even without surgery, the same process can take place. But surgery is considered to be a procedure which hasten or which fasten the procedure of lengthening of soleus. So that was about the muscle strength part. Now we are coming to the lever arm dysfunction for the soleus. There are few problems which we see in cerebral palsy children which leads to a lever arm problem. So let's take a planovalgus foot. This is a very common problem which we see in diplegic cerebral palsy children. Now the question we want to understand is like, how does planovalgus foot reduces the lever arm? So let's say that this is the foot with a good arch. So this is the foot with a good arch, and this is what the lever arm. One end of the lever is the second metatarsal, and the foot itself is working as a strong support or a lever, and on which the body weight acting in the form of from the tibia, and on the other end, the muscles are trying to carry out to lift the foot. So this is what the normal lever arm in a normal person who has a good arch. Now the same planovalgus foot, because of the midfoot break at the talonavicular joint, there is a reduction in the length of the lever arm. You can see that previously the length of the lever arm was pretty big, while here it is small. So as shown in this figure, the planovalgus foot reduces the lever arm for the soleus. Okay, then we see many children who has an external tibial torsion, and because of that, they walk with keeping the toes out toeing gait. So if we look at this diplegic child, he is walking in the direction of the black arrow. However, his feet are pointing in this direction. They are pointing outwards. So the next question is this: how does out-toeing reduce lever arm? To understand that, again, we are looking at the same picture, that this is what the length of the lever arm. Now, to understand it better, we are looking the same foot from top, and this is what the length of the lever arm in a normal person. Now let's take the same foot. We are not taking the midfoot break into consideration. The same foot, if it points outwards like this, in that case, now the same points the head of the second metatarsal and the calcaneum. And if we look at the distance, the lever arm is reduced. To make it clear, I am taking out all the other bones from the picture, and we are looking at the lever arm. This is what the person with a straight feet. This is on the red, the person with a out-toeing gait. And we can see that there is a reduction in the length of the lever. So this is what the reduction is. So external tibial torsion reduces the lever arm of soleus. And then the third point, a positional lever arm. Positional lever arm is like by changing the position of the joint, what is the effect on the muscles? So let's take that this is what the normal ankle in an upright posture. And if we look at the lever arm for the soleus, it is from the center of the ankle to the tendon length. So green is the lever arm. Now let's take the same person. There is no change except there is a dorsiflexion at the ankle. And if we look at now, the lever arm for this person is this much. To give you the comparison between the normal upright posture and ankle dorsiflexion, this is what the difference in the lever arm. So here foot is not playing role. There is nothing about the muscles. It's just the change of the ankle position that leads to reduction in the lever arm, and that affects soleus. So if we combine that ankle dorsiflexion also reduces the lever arm for the soleus. So if we combine, there is a elongated soleus by surgery or by natural mechanism, plus there is a planovalgus foot, plus external tibial torsion, and a dorsiflexion at the ankle because of the crouch gait. All this to combine leads to inefficient soleus. And how this inefficient soleus leads to the problem in walking. To understand that, we are now looking at the initial part of the stance phase. We are looking this person from the right side, and this person is moving like this. So this forward progression of the tibia is controlled by soleus. And when soleus is affected from the strength point of view or from the lever point of view, these forward progression of the tibia is affected. So let us understand that in a normal person, when soleus is effective, the lever arms are good. In that case, at mid stance, the tibia will not progress beyond 10 degrees of dorsiflexion. However, when all these factors are abnormal, that results into inefficient soleus action. And in that situation, the forward progression of tibia does not stop at 10 degrees, but it continues beyond that. And that results into more dorsiflexion at the ankle. And when there is more dorsiflexion at the ankle, the body has to compensate by flexing the knee joint. Okay, so now coming to the second question, how quadriceps is affected in this process, or what are the issues at the quadriceps muscle level? We have understood that, or we have seen that patella alta is a common problem, particularly in patients with crouch gait. We don't know whether it's a crouch leads to patella alta or patella alta leads to crouch. We don't know which starts first, but let's understand how biomechanically this affects the quadriceps muscle. So This is one X-ray where we can see that the patella is high riding, the patellar tendon is long. What happens when patellar tendon is long? To understand that, we are looking at a normal person when the patellar tendon length is normal. And when this person tries to carry out knee extension, there will be a full knee extension. On the other hand, if we look at a person whose patellar tendon is elongated, the patella is lying higher position, means we call it patella alta. Now, when this person tries to carry out knee extension, he will not be, or she will not be able to carry out the full knee extension, and that results into inadequate knee extension, active knee extension, which we call it extension leg. Now, if we try to understand that how this leads to a problem, if this is a person with an extension leg, when this person becomes upright for walking like this, the knee remains in flexion because quadriceps cannot extend the knee joint. So again, person keeps the knee joint in flexion, and that is what the crouch gait. Again, the patella alta reduces the lever arm problem, and how it does the reduction in the lever arm. One of the important function of patella is to provide the good lever arm for the quadriceps mechanism. So if we measure the distance from the center of the knee joint to the center of the patella, this is what the lever arm for the quadriceps mechanism. Now, on the other hand, if we look at when there is a patella alta, the patella has gone up, and if we measure the lever arm for the quadriceps mechanism, it has become less. To compare the normal and the abnormal, this is what the difference is. There is a reduction in the lever arm of the quadriceps mechanism because of the patella alta. So patella alta reduces lever arm for the quadriceps muscle. And in addition to that, many children have a flexion deformity at the knee joint. It affects them very differently. And to make this point clear, let us take a situation that there is a flexion deformity at the knee joint. And this child or this person can walk with the ankle in a neutral position or in plantar flexion, as in a jump knee gait. The other option is the same person with the same amount of flexion deformity keeps the ankle into dorsiflexion as if there is a crouch gait. And we can see that if we compare the stability point of view in both the question, the stability is much more in a crouch gait when ankle is dorsiflex. And one of the important prerequisites for walking is stability in the stance phase. And that stability is achieved by ankle dorsiflexion. So knee flexion deformity is another reason for crouch gait. So the take-home message is crouch can be because of the reduction in the strength of the muscles. We saw various reasons how strength can be reduced, or it could be because of the lever arm problems. We saw various lever arm problems which leads to reduction in the quadriceps and the soleus strength. The muscle weakness can be because of the primary impairment neurological problem, because of our treatment ankle foot orthosis, because of the botulinum injection, and sometimes because of surgical treatment. The lever arm problems for the soleus can be because of the external tibial torsion, the planovalgus foot, and the positional lever arm problem. The lever arm problem for the quadriceps is patella alta reduces the lever arm for the quadriceps mechanism. And fixed flexion deformity at the knee can result into jump gait or a crouch gait. But crouch gait is a more stable gait, and that allows patient to walk with a more stability in the stance phase. A lot of patients with a flexion deformity, they adopt a crouch gait. So what is the practical implication of this? Whenever we see a patient, and that we are going to discuss in the next case, we need to identify what are the factors which are responsible for the crouch gait. So once we identify them by clinical examination or by various tests, we need to treat them, as many of them as possible, by non-surgical options or by surgical options. So with that, I stop sharing, and I will be very happy to take your questions about this.
So that was a fantastic presentation, and I must tell you that the residents, I mean the fellows, would learn quite a bit the complex intricacies of crouch with these animations. So my first question is, I'll start the ball rolling, that we know that the soleus weakness is one of the profound cause of crouch. And at times we know we can work on patella alta by reducing length of patella tendon. We can correct the deformities at knee. But in some patients, mainly soleus weakness is the only cause. The hamstrings are of adequate length. There's not much patella alta. Is there any advances in shortening of soleus in literature is done or not? I mean, we don't see that surgery frequently, while main cause is soleus.
Yes, exactly. So let's understand that what we are understanding is like there is a muscle length and there is a tendon length. The problem with the soleus lengthening is the problem at the muscles level. And by doing a surgery at tendon level in the form of shortening the tendo Achilles is actually not the right treatment for that. But at least we can take care of some of the problem which is at the muscle level. If we really want to do something, then we need to identify a surgery which can shorten the soleus muscle. But again, remember that length and the strength, they are different problems. So right. we cannot we can shorten the muscles, but we cannot gain the length, or we cannot reduce the length, or sorry, we cannot increase the strength. So that is what the right. We are limited with our surgical options for these patients.
In those cases, we ask the families that they have to. Yeah, Gupta ji.
Yeah, Dr. Dhiren, fantastic as usual.
Thank you.
So very nice concepts actually. I just wanted to ask this a question similar to Maulin's question. Is that in some of the cases where somebody has done a tendo Achilles lengthening, right? Do you have ever considered a shortening of the tendo Achilles where there is a lot of overstretch, and what are your results?
Okay, that's another very important question. See, once you create a problem and its effect is seen in the form of a overstretching of soleus, by reversing that procedure, it's very unfair to expect that now muscle will recover. So the best thing is to prevent that surgery, to avoid such surgery. But once we do it and then reversing the surgery is not going to take care of them. Whatever damage has taken place at the muscle length issue at the soleus is already taken place.
I mean, you substitute it with the ankle foot orthosis. Actually.
Yes, exactly. That is what we are doing. But like, see, once you substitute it by restricting the dorsiflexion, that is what we are offering to the treatment, but that is not the correct treatment.
I mean, some of the cases, there is a lot of stretching of the gastrosoleus complex, like tendo Achilles. Almost it is in dorsiflexion. So some 2 or 3 cases, maybe I have tried the shortening where it was grossly lax, where the previous surgeon had done a lot of tendo Achilles lengthening. So, I mean, I would not say the results were excellent, but they were a shade better than before. So I don't know what is the experience of.
Right.
Yeah, so like my good friend Reinhard Brunner has tried this surgery, the tendo Achilles shortening in view of the patient. He has analyzed the patients with gait analysis. But yes, there is some improvement, but we cannot expect a miracle out of that procedure.
No, it's not a miracle, but
that is, the problem of strength and the length at the muscle cannot be compensated by tendon shortening.
No, I agree with you. I agree.
Another question, Dr. Dhiren Bhai. In some patients with long-standing crouch and ankle dorsiflexion, we are not able to plantar flex the foot. Have you tried lengthening tibialis anterior or some anterior ankle structures to bring, and what is your
Yeah,
take
very
on?
good question. And actually, today morning I was thinking about this question because this is a very important thing, that when patients has a long-standing crouch, many of them, they develop dorsiflexion contracture at the ankle joint. And the first step in the surgery is to get ankle to the neutral position. And I have done tibialis anterior tendon lengthening to gain or to bring the ankle to the neutral position. Because if you don't do whatever you do it at higher level, the patient is going to still walk with the ankle in dorsiflexion. And ultimately, to gain stability, the patient will flex the knee joint. And ultimately, the whole surgical aim will be lost. So yes, you are very right that we need to have, or we need to bring ankle to the neutral position. And for that, I have tried tibialis anterior lengthening.
So that you do in infraretinacular, right?
No, this can be done at both the level, but this for ankle dorsiflexion, I have done it at above the retina.
Okay.
Do you consider a fractional lengthening of tibialis anterior, or do you do a Z type procedure?
Frankly speaking, I have done the tendon lengthening for the tibialis anterior.
Okay, Dr. Patrick Kuran is here from Reddy's Children. Good morning, Patrick, or
Yeah,
it might be
welcome.
good evening.
Yeah, it's good evening here, but good morning to you. It's so nice to get to join you guys. Thank you for a wonderful talk. I learned a lot. I thought those animations were fantastic. That's probably the clearest talk on Crouchgate I've ever seen.
Yeah, so Dr. Dhiren has great concepts and capacity to convince and educate the trainees. Any question, Patrick, or your input about this topic will be appreciated.
No, I really enjoyed it. I thought that all of the points were very solid. I would say one of the things for Crouchgate in terms of the maintaining the relative position of the tibia relative to the foot and those who have an over-lengthened Achilles, really, I think that the AFO is critical for that one. And oftentimes we'll use a ground reaction AFO that helps to restore the plantar flexion knee extension couple. So for the residents who aren't aware of that, that's the AFO that goes up in the back and then loops around the front of the tibia to push the tibia back in mid stance and help drive the knee back, in addition to your kind of multi-level surgery. The one question I had just regards to some of the causes of Crouchgate that I don't think was necessarily addressed is in regards to some of the transverse plane issues higher upstream. How often will you tend to address problems like relative femoral anteversion in these cases at the same time as multi-level surgery because of the effect of lever arm dysfunction upstream on Crouchgate?
Yes, the transverse plane problem leading to the Crouchgate are not really understood, particularly like, see, we deal with a lot of patients who have an increased femoral anteversum. But how does it improve the Crouchgate? I'm frankly not clear biomechanical point of view. So that is why I have not discussed that. It definitely improves the mechanism, abductor mechanism, because it improves the mechanism or like the lever arm issues for the abductors. But then it's a different plane problem. It does not improve the crouch issue directly. That is why I have not covered that. But yes, when we are dealing with or when we are looking at improving the gait, correction of the femoral anteversion is one of the important component of surgery. But frankly, as I said, that I'm not well convinced about like it has a direct effect on the Crouchgate.
So Patrick, my question to you is like, we see a lot of rotational malalignment, femoral anteversion and tibial extorsion, and you have the access to gait analysis labs, right? So
Yes.
do you have experience of improving those kinematics and kinetic parameters after doing torsional realignment? And how it is different from the only crouch management?
Yeah, well, I think for kind of the spectrum of diplegic gait, in kids in whom you see transverse plane issues, you can see improvement in their kinematics and also their observational gait analysis by correcting that. I mean, going from bottom to top, from the talk that we talked about here, kids who have pes planus, who have external thigh foot axis or foot progression angle, you see that both clinically and kinematically with correcting their flat foot. Kids who have external tibial torsion, again, you see improvement of that with their kinematics and kind of up the kinematic chain. So yeah, I think that you do see improvement with it.
So why I asked this question, because doing all these bony corrections at foot level, tibia level, femoral level, become a bit too lengthy procedure. So sometimes we stage it. We do the crouch correction, patella plication, foot correction, and then we give some time to the child and come back after some time if they have issues with the gait and walking endurance and this lever arm issues. But surprisingly, in some children, even though their rotational malalignment is compensated, they do well and they don't opt for further surgeries, that they say we are fine with it,
Yeah, I think that's totally fair. I think some of it gets to the dosing for the child, how much of a dose of surgery to give that's right for them in terms of their kind of mechanical problems, and then also in terms of their developmental problems and their overall weakness and neurologic problems and how functional they really are. As an example, I have a girl that I have scheduled for surgery this next Monday who has crouched gait. She's a GMFCS3B, so a poor GMFCS3, a lot of intellectual delay, and has become greatly deconditioned after the COVID pandemic without access to therapy and going to school. But her biggest problem is she has a lot of femoral anteversion. She walks with her feet in with crouch. And for her, you could find things to operate on every single level, but whether every single level is the right thing for her, can she handle the surgery and can she handle the rehab is another big problem.
Yeah.
So for her, I think less is probably more. And so I'll focus on her femurs and then get her into ground reaction AFOs and try and get that to drive her knee back and try and control some of her crouch gait there. But she would have uncorrected pes planus, and she should have some uncorrected external tibial torsion.
Yeah. Great. So last question by Chinmay before we go for a case presentation.
Yes,
Chinmay, your question to sir.
Yes, Dhiren sir, I have a question. When we have a crouch gait, when they are skeletally immature, let's say below the 10 years, do you have the treatment plan tailored according to the age and the bony skeletal maturity when you go for the extension osteotomy and when you go for the symmetry transfer or the epiphysiodesis anterior?
Okay, that's a very important question. And that's the third point, like what surgeries needs to be carried out or like how part of the crouch gait. So let's see the case and probably that will help us to have some discussion about the management point of view. But age does matter, how you are correcting the flexion at the knee joint. Yes, that's a very important point. Yeah. So let's see the case and probably we will try to discuss these points in that.
Right. Sheena, would you like to share your screen?
Yes, sir.
So Dr. Sheenam is our current fellow and she would present a case which we operated before about 2.5 years.
Hello, everyone. 12 years old female presented to us with inability to walk independently for longer distances. She was born full-term by cesarean section. There was no history of postnatal complications. There was history of one episode of febrile seizure at 2.5 years of age. She started independent walking at 4 years of age. She didn't underwent any orthopedic intervention so far. She presented to us with this gait with a flexion deformity at hip and knee, and we can see a crouch gait pattern is there. On clinical examination, there was hip abduction 45-degree on each side. There was no hip fixed flexion deformity or rectus femoris spasticity. There was no knee FFD. Popliteal angle was on 60-degree and R2 was 40-degree. There was no change with popliteal shift. Patella alta was present. Ankle dorsiflexion with knee flexion was 10-degree. And with knee extension, it was 10-degree plantar flexion, which was suggestive of gastrocnemius spasticity. There was no rotational malalignment. Knee extensor leg was 30-degree bilateral. And there was moderate selective motor control.
Yeah, so Shinam, can you go back to that slide?
Yes, sir.
Go back. So Dhiren bhai, should we play that video again? This is the clinical exam. Hip abductor spread is looking okay. No hip or knee flexion deformity. Popliteal angles were also not very high, and patella alta was significant. Although the foot looked plano-valgoid, but with the foot inverted, the passive ankle dorsiflexion with knee extension was around -10 degrees. And there was plano-valgoid feet and mid-foot break, as you could see. So here is
So
the case.
shall we like how I come
Yeah.
to the decision making based
Yeah.
on the information we have? Okay. So the first thing which I do, so this is my thinking which is taking place inside the brain. The first question I ask, is there a flexion deformity at the knee joint? The answer to this question is no. So when there is no flexion deformity at the knee joint, all the other things which we understood for the foot, for the soleus and for the patella alta, we have to take care. So at the knee level, there is a problem that is patella alta. That goes with the clinical examination with the extension leg also. So yes, we need to correct the patella alta. When we come to the ankle and foot portion, there are three issues which are playing role. The first is planovalgus feet. It is there. So we need to correct that. When we correct that, we have to take care of the gastroc length because there is a change in the dorsiflexion with the knee flexion and knee extension. So we correct the planovalgus foot. We correct the gastroc length, means the stress procedure with that. There is no tibial extorsion, so there is no need to correct derotation of the tibia. The lever arm problem of the soleus a positional lever arm problem will get corrected automatically as soon as we improve the problem at the ankle level. The only thing which I am not sure from the gait analysis or from the video and from the clinical examination is like, what is the role of hamstrings in this overall situation? It's only the crouch or the knee flexion is only because of the ankle issue, or hamstrings are also playing role in that. That is only one thing I will be not tell very confidently from examination and from that. But if they are short, in that case, I would go for the semi-T transfer, because we are not burning our bridges. We are not really causing great loss at the hip level. And so my prescription will be striers with the planovalgus foot correction and patella alta correction. And if required, something semi-T transfer at the hamstrings. That is what will be my prescription.
So we had the same dilemma that usually with this sort of gait, we would see some degrees of knee flexion deformity. But in this case, when child was on couch, she didn't have any flexion deformity, and popliteal angles in adolescent, a 45-degree R2 should be considered as normal, but we very categorically performed popliteal shift and it was not reducing further. So Patrick, what would be your take before we show what we did?
I think I'm in a similar camp. I'm a little bit confused about the hamstrings there. I'd expect for her gait pattern for them to be a little bit tighter than that, but I think your clinical exam is what it is. So I agree, the semitendinosus transfer doesn't burn a lot of bridges and gives you a little bit of length there, and turns it from a biarticular muscle into a monoarticular muscle. So helps to maintain some of your, in theory, pelvic retroversion. So I think that that was fine. I would agree with everything else that was said in terms of plans for correction of her pattern.
Yeah, so we do not have access to gait analysis yet. And so we had to rely on our clinical exam and the visual gait. And let's see what we offered. Shinam, can you, and what are the results? So you can comment further on it. Shinam, can you go ahead? Yeah.
We did bilateral semitendinosus to adductor magnus transfer, high TA aponeurotic lengthening, and Mosca's procedure. Tibialis posterior plication was performed and patellar tendon plication was performed.
So we did the isolated gastrocnemius aponeurotic lengthening and the typical calcaneal lengthening with medial plication. And we did not touch the semimembranosus or gracilis and rectus femoris. We just did the SAMI T2 magnus. So by and large, we performed what Dr. Dhiren Bhai mentioned. Dhiren Bhai, do you have any comment on this?
No, absolutely. I have suggested exactly the same thing.
Yeah.
Same thing.
The Patrick, you would have done something different than this, or this looks okay?
No, this looks great to me. I haven't actually done a tib post plication, so I'm very intrigued by that. That's a nice idea.
So we tried, because once we correct the lateral column, we see that the medial tip post is very lax, and then we try and plicate it over itself, and sometimes with the talonavicular capsule. So that's what we did. Yeah, please
Only
move.
one thing I would like to add. I'm sure that you must have covered that in the Mosca's procedure, the peroneal brevis lengthening. I think that's a part of the Mosca's procedure. I understand.
Yeah, so that in this case, after doing calcaneal lengthening, we did not find peroneal brevis becoming very tight. So we do that Z lengthening in infraretinacular if with peroneal tendons become extensively prominent, but that was not the case in this. So we did not touch it. But we do that if we find it becomes very tight. How frequently you need that in your patients? In all cases?
I do it in all the cases. So I don't decide poroperatively. Before doing the calcaneal lengthening, I do it above the retinaculum. So I do it supramalleolar.
So that fractional lengthening you do?
Yes, fractional lengthening.
Oh,
yes.
Yeah.
Yes.
I think if you're planning to do a vulpius, which you would not be doing in this case, or but if you're lower down, you can do a recession of the peroneus brevis to the same incision, or kind of same proximate.
Yeah. Yeah, Shinam, can you move ahead and show the clinical results?
We can see before and after 1 year gait analysis.
That's fantastic.
Yeah, this is super. Still, knee goes into flexion to some extent. Yeah, but this is what we see. Like,
can you show it
make them
again?
normal.
Yes.
Shinam, the sagittal view you have, the side profile. Anyways, so there is certain degrees of external foot progression angle, but this is what I mean. I place around 14 millimeter of iliac crest graft, and this is without AFO. You have next slide, Shinam, the slide. Yeah, so this is the side profile at 1 year with and without AFO. So these are the static But she always walked with more speed and more confidence without orthosis than with orthosis. Yeah. Move ahead, Shinam, and okay.
So this is an excellent example, like the concept which we discussed in the lecture, and the same concept when applied on the patient, we get the good result.
See, the one more important thing which I always explain to the family is that don't let the child put on a lot of weight, because increasing weight leads to worsening of
Naturally,
outcome.
it reduces the center of gravity, brings it down. So that's a very clear thing.
And we know with the GMFCS curves, they fall to a certain extent. But I try to make them join some weight training and gym once they are confident. So we have 2.5 years follow up this girl. Can you show that, Shinam?
Yes.
So this yesterday night, we asked parents to send a video, and she has placed a lot of weight. We can see that, but her walking endurance has not gone down. But I warned them again that
this is going to be a problem because this weight gain.
Yeah. So, and do you think that there is some anterior pelvic tilt also? But so again, they have to, do some corrections with the diet, and her intellect is moderate to good, so it's not easy for parents to get things done. She would do at times, and at other times she would not. Yeah, Patrick, your comments?
I think this is an outstanding outcome for a very decompensating gait pattern from the beginning, with a relatively straightforward procedure that should be capable of most pediatric orthopedists. For the residents, we talked a lot about access to gait labs and whatnot, but I think for me, the most powerful tool that I have is my iPhone that I have in my pocket in clinic every day. And any kid who has a gait deviation, I just take a video of them walking towards me, away from me, and from the side. And then I just play it back for myself on slow motion and break it down in slow motion, because that's really what you need, is to take that and take time to really understand where they have gait problems. And you can do that with your kids, you can do that with adult patients, but it's helpful for thinking about things and playing them out. But you should be congratulated. That's a really nice outcome there.
Thank you. So before we wind up today's session, Dhiren bhai, last few comments for our fellows and residents. And there are some physiotherapy colleagues as well.
Yes, so basically the crouch, according to me, there are two types. The one with the flexion deformity of the knee, where results are really predictable.
Shinam, can you stop sharing your screen? Yeah? Yes, sir. Please go ahead.
Yeah, the second variety is the one which we saw in the case discussion, where there is no flexion deformity. And at that point, the two issues which we discussed in the lecture about is the strength issue of the muscles and the lever arm problems correction. They are really important. And again, we need to remember that all these corrections, they are not dealing with the primary pathology of the weakness. So still these children are weak compared to the normal population. And because their muscles are weak, we are really worried about weight gain, because their muscles have a limited capacity to take the weight. And as soon as their BMI increases, the muscles, once upon a time, they were adequate for a particular BMI. As soon as the BMI increases, they start becoming inadequate. And that leads to further increase in the crouch, which has disappeared. So I'm really interested to see the follow-up of this child with the weight gain, what is happening to that. So, but my observation is like weight gain is one of the detrimental factor in the crouch gait.
Right. So we have a few more questions, sir, but we'll take, Dr. Shinam will post you on your WhatsApp. Sure. And your answers will be posted on the fellows group. So thank you very much for your time. Thanks, Dr. Patrick, for your time and valuable comments. We are so happy that you could find time and join. Thanks, Chinmay, for connecting us to Patrick.
Thank you, sir.
And thank you, everyone. Take care.
My pleasure. Thank you for letting me join.
Patrick, give my regards to Hank.
Oh, I will. I'm with him tomorrow in our CP clinic. I'll say hello for you.
So like say what I discuss in the lectures, a lot of credit goes to Hank because like he has taught me all these concepts. So like